Hi, good afternoon, everyone. Welcome to the breakout session, DHS Involvement During Pregnancy and Birth, Setting Expectations and Navigating Discomfort. I am Bonnie. I am just here to introduce Kiante Holmes, who is our speaker today. I'm also going to be wandering around the room at the end during the Q&A portion to make sure folks get questions answered. When I do come to you, I'm going to have a mic. Sorry if that freaks you out, but we also want to make sure that this all gets recorded, and so please speak into the mic for accessibility. And Kiante is here to talk with us on the topic. She is from Providence, Portland, Labor and Delivery. So please welcome Kiante, and off we go.
Hello, everyone. So I'm talking about a topic of discomfort, and I'm just going to throw that out there. I'm very, very uncomfortable right now. So I was thrown in from our Project Nurture team. So they always think, as a social worker, we're great talkers. So do this presentation, you're great at it. So I'm really, really nervous right now. So just throwing that out there. Well, thank you guys for being here. I definitely appreciate it. So my experience, again, I'm Kiante Holmes. I am a Portland native, born and raised here. I've worked for child welfare for 7 years, and I currently work for Providence on labor and delivery. I am the social work NICU lead. I also partner with our Project Nurture, and I sit on the substance use disorder board for Providence. So that's about me. So today I'm just gonna give you guys just tools, just how to support. We're gonna talk about, again, language. As we heard from Sarah, we heard her story. Thank you for sharing your story. Thank you. And that's one of the reasons why I'm here, is to talk about language. And so a lot of us will work with DHS if we haven't already, especially when we have patients or people that we work with that have substance use disorder. And it is very important when we talk about language and how to support. So that's one of the things that we're really gonna talk about today. And then also, again, some of us are mandatory reporters. As a social worker, I'm a mandatory reporter. Some of you guys in your jobs are mandatory reporters. Some of you guys may not be mandatory reporters, but I'm just going to talk about a little bit of mandatory reporting here in the legislation around substance use disorder and mandatory reporting as well. So one of the topics is, why do people use drugs? Sometimes people use drugs as a way to cope from negative life experiences. Some individuals who become pregnant, that's another question, is if they're pregnant and they know they're pregnant, why don't they stop? That's a common question. Why don't they stop? Sometimes when you're pregnant and you're trying to stop, the withdrawal is more severe. So that's one of the things that we're also going to break down and talk about as well. So the Comprehensive Addiction and Recovery Act of 2026, known as the CaRA, it was created requirements for states through the Child Abuse Prevention and Treatment Act, CAPTA, to focus on the impacts of substance use on infants and their families. The purpose is for early indication and intervention by providing support. Again, I'm going to emphasize providing support and services. Specifically, the law requires healthcare providers to notify child welfare when an infant is born affected by substances. Again, so it is our duty and our job to notify child welfare when an infant is impacted by substance use. B, plans of care to be developed for such infants to address the health and substance use disorder, treatment needs of the infant and the infant's family. So that's once an infant is born, if they need additional supports and services, how do we navigate that? And then C, service referrals to be made for any services identified in the plan of care. So that's ongoing supports and services and different things like that. Approaches to consider when working with a family, whether you're working with the family inpatient or outpatient. So we already know the law is that we have to report. That's something to consider when we're working with our patients, is at some point we may have to report. And so that's important in understanding that. And so when you're working with the individual, first, in knowing that, the transparency, it's important to be able to communicate that to them before that call happens. Of, hey, at some point, I'm going to have to make this call, and explaining to them why you have to make that call. Permission. Sometimes what we do in our clinic is that we ask the question, hey, I have to make that call, but do you want to be a part of this phone call? Do you want to be able to, do you want to make the phone call yourself? Or do you want to be present in the room as I make that phone call so you can understand the things that I'm saying or understand what's happening on the other end? Normalization. Again, it's important to communicate what's going on, what's happening. When you're working with the individual, a lot of them, when we start to talk about DHS and different things like that, there's going to be a lot of fears. There's going to be a lot of, maybe I don't want you to make that phone call. Please don't make that phone call. So it's important to be able to talk to them to understand what's happening at that given moment. Of, hey, sometimes they come in with history. Sometimes there's personal history, there can be family history, or sometimes if individuals are houseless, they have different stories from other individuals that are houseless, that are on the street of why not to call. Or they already expect certain things that may or may not happen. So it's important to be able to have that dialogue and to have that conversation with them. And then respect. Respecting where they're at. We may not understand everything. We may have never experienced someone with a substance use disorder. So we may not know what's going on for them, but respecting them and where they're currently at. And then trust. The one way that our patients will build trust with us is if we're open and honest. Never promise them anything that you don't know or that you can't keep your word. Like, for instance, I know your child's not going to get taken away. That's something that we don't have control over. So that's something that you wouldn't want to promise them that. Or I'm going to be here with you every step of the way. We know as care providers, the jobs that we do, we're going to try our best to be able to support and to be able to advocate with that patient, but we don't want to tell them things that we really cannot fulfill. And so that's how we can start building trust with them. Also, just being honest. Hey, I've never experienced this. I don't know, but I can give you the resources, or I will go ask someone or bring someone in that may have these questions, that have these experience, that can be able to help and support you. So again, looking at the Maslow hierarchy of needs. So when we're looking at the person as a whole, we want to know, we want them to be able to trust us. And so the biggest thing is understanding their story, understanding currently what is happening for them, what are their needs. A lot of the patients that I see on the labor and delivery is they haven't had medical. They're hungry. They're tired. So if I can just do one thing for them at this given moment of, let me go get you a sandwich. Let me go get you something to drink. Let me get you clean clothes. So just asking them, what do they need? They're already uncomfortable, especially if they're in a medical situation, of asking them currently what it is that you may need. I can't change the situation, but let's see how I can support you at this time. So one of the biggest things is trauma-informed care. And so in looking at trauma-informed care is language. It's very important when we talk about language and understanding things that may be acceptable for someone who has a substance use disorder for them to say or their friends to say, but from a medical perspective of the things that we should be saying. And then it's also important, again, to meet the patient where they're at, to understanding currently what their needs are, where they are at in their recovery phase, who are their supports, who are they already working with. That's just important to understand to be able to get to know them. So the next one we're just gonna take, it's again, language. And so this is broken down just by just certain situations and who you are. So it's important to, when you're looking at this, when we're talking about language, is identifying who you are and how are you helping that individual. And so that's where this word, or some of these words that are broken down are. So as you see, I'm a social worker. I use the word someone who has a substance use disorder. It would never be appropriate for me as a social worker to call someone an addict. Let's see. I'll stay on this for a while. Does anybody have any questions about this slide?
I don't have a question about the slide specifically. How do you suggest integrating this language when we have so many folks on our team with different lived experiences, and not everybody has the same trauma-informed training and language?
So I think I get your question, but my response would be to ask, because there's certain lived experiences and it depends on the situation where it would be okay to use certain language and certain words. And depending on where you're at, I would ask the people in the room, is it okay for me to use this word, or is it not okay for me to use that word?
Just wondering what's green, why is it green and the other one says stop? And what does the first column up top say?
Oh, perfect. Thank you. So on the very top, it says for the first line, it says mutual aid in meetings. So that would be like an AA meeting. And so based on the situation where it's checked, it's saying that would be appropriate. But in the public or with clients, medical settings, and journals. So like if you're writing about different things like that, so that there's telling you up top that wouldn't be appropriate to be able to use certain words and language.
I'm looking at the columns, and if mutual aid meetings means like NAAA, all the what do we just call support groups?
Mm-hmm.
Is this chart telling me that saying substance abuser or medication-assisted treatment would be inappropriate?
Actually, yes. So, yeah. So I think that's important to look at as far as identification and how to talk about certain things. But I think it's important, I think from her first question, what she said is like who you are as a person in the form of looking at recovery, and how to be able to use these words and when not to use those words.
As a person in recovery, I think it's important to point out that you can use whatever words that you want to describe what you have going on, but even in like a meeting setting, like if I point at them like you're an addict, well, that's not really, unless they've given you permission. So that kind of helps in the settings too, whether you have lived experience or not. It's just better that it's a little bit of a harsher type of language that you can self-identify with, but don't put that on other people.
Yeah. Perfect. Thank you. Thank you guys for that. Any more questions? Perfect. Things to consider. Concerns around our own personal safety. So this is talking about at the point where you feel like there may be a situation where you're going to have to call DHS and get DHS involved. And so, and looking at all that's going on and working with the individual, how do I encompass all of this? And so we know sometimes we're going to have feelings about certain situations and certain things, or an individual that is in the room that we're working with. And so in looking at that of what is currently happening, even for myself, before I make that call, like how am I feeling and what am I doing as far as that goes? And checking in with yourself. I think that's very important because kind of what we heard from Sarah's story about what was presented in the room was some assumptions about what was happening and what they were doing. And so I think that's very important to check in with ourselves, to check in with other people in the room about, hey, this is how I'm feeling. How do I move forward with that? And things like that. And looking at the other staff. Sometimes when you're in the room and you're working with someone, whether it be inpatient or outpatient, when working with substance use disorders, it's forever evolving and we don't know everything. And so it's important to talk to your colleagues about what's going on if you don't know certain things. And then most important, if you are inpatient, what is happening after a baby is being delivered? What is happening to that newborn? And so at that point, when a baby is delivered, not only is the mother our patient, but also the baby is our patient as well. And so we're working with two individuals. And so that's important to be able to talk to our families about that of, I understand that I'm working with you, but I also have to keep the baby safe. And this is also what I'm working with as well. And then who else is in the room? So if there's families present, how are you working with them? How are you communicating with them? How are you talking with them? That's also important as far as that goes. And so when we are inpatient, and we have a baby that has been delivered, these are the things that we consider as far as, again, what is the baby's needs? Specifically, as a social worker, even though I work in inpatient, I don't know everything that's medically going on. But I know at the end of the day, I'm going to be the one to make that call. And before I make that call, what I want to do is understand medically what specifically are the baby's needs and what is going on and how it's related to child abuse and neglect. And so that's the most important thing is when you are making that call, how is the baby's care related to child abuse or neglect? And as a social worker, I'm going to be working with the medical staff and the nurses to fully understand the scope of what is happening with that baby. It's important to talk about transparency. When we are working with the mothers in this situation of understanding currently what is happening? How am I communicating that, again, if I have a concern around child abuse and neglect, I'm going to be making that phone call. I have to make that phone call. But before I make that phone call, is the patient aware that I am making that phone call? Me personally, at Providence Labor and Delivery, if a mother does not know that we are making that phone call, unless there's, a safety issue of why, we do not make that phone call until they fully understand that we are making that phone call, and this is the reason why we have to make that phone call. It's about, again, building the trust and building that relationship and being able to support of currently what is happening. In trauma-informed care, we don't want to cause more harm. And so if you do that, if a parent doesn't know that you are making the phone call, it could cause more harm and also create a bigger safety issue within itself. Because if that mother decides to leave with that child, that you have to get security involved, different things like that, that's causing more harm, and it could create a bigger safety issue. And so that's something to be able to talk about and to be able to figure out of how do we navigate this? How do we work with the mother in understanding that this is the concern and this is why we have to call, and these are the next steps that we have to take. And so that's what we feel like is important, to be able to build that relationship with our patients. And then permission. So one of the things around permission is who's in the room. Because sometimes family members, significant others, or whoever else is in the room may not know that this individual has a substance use disorder and things like that. So before coming in the room, it's important to know who's in the room. And before disclosing personal information about what is happening, ask that individual, hey, I need to talk about something that's related to the care of you and your baby. Is it okay if we have an open conversation? Do you want me to come back? Or if it's something that has to be done right now, hey, is it okay for your guests to go out to the lobby while you and I have this conversation? It's very important to, when we establish the relationship, when we establish the trust, to being able to communicate that. Because sometimes what happens is there may be their support person in the room, and they may not know that the mother or the baby just tested positive. So it's important to identify who's in the room, and before you disclose certain things, that the mother is giving you permission to be able to have these certain conversations with everybody that's present in the room. Normalization. And so it's important, once we're having this conversation, to normalize how they're feeling. It's okay for them to experience anxiety. It's okay for them to be worried. When they're having these feelings of anxiety, worry, it's not that they're not telling us the truth. It's that they've probably had experiences with child welfare or heard situations. They've never gone through it. So it's important to normalize what is happening. And to just give them the respect to be able to understand what is going on. And so again, if I've never experienced a substance use disorder, or I may have never even worked with someone who has a substance use disorder, it's important to be able to communicate what's happening for you. I noticed when I'm talking to you, your heart rate raced a little bit. You just got silent on me. You started crying. Can you explain to me what's happening? Do you want me to leave the room for a second? Is there something or someone that I can get for you to be able to be a safe person to be able to talk about? It's important to name those things, what's happening. And then again, like I said, things to consider. especially for some patients who have multiple children, who children may already be out of their care. They may have already gone through an ODHS experience. They may feel very isolated in the situation. They may not have supports. And so it's important to be able to talk to the patient and see who they have, who are their supports. That's very important, of who their supports are and who can help support them, and then navigate from there. I think that's very important. And it's up to them to name who their supports are. It's not us. It's not up to us to identify whether that person is a positive person or a negative person. It's important to let them identify who their supports are, what they may need in the situation, and then navigate from there. And then again, it's important to know our role in the situation, who we are. I'm a social worker. My job is to make sure that we have a safe place and things are happening for the baby, but also to get you the supports and services as well. And so it's important to identify who we are as far as what is happening in the roles and what is happening in the situation. And then before you make that report, it's important to understand the facts. What is happening with the baby and what is happening with the mother. Sometimes a mother may just be tired, right? She just had a baby. She's been pregnant. It's not that she's coming down. It may not be she's just using the bathroom, but it's to know the facts, know what's happening with them, and make sure we are properly communicating that. So if we're going to, whether we're making a hotline call, and making sure that we are properly answering the questions, not to our judgment, but what is actually happening in the situation. All right, that is my last slide, so I will take questions.
I just wanted to ask a question about the CAR Act, and my understanding is that there is a difference between making a child welfare report and then notifying child welfare. So I don't know if you could clarify for us, like in that CAR Act, what the federal government is asking us to do in terms of reporting child welfare. My understanding is that every infant that has been substance exposed needs to be notified for data collection, but that a child abuse report is needed when there is child abuse that's happening. And then in Oregon, child abuse by itself is not, or substance use alone in pregnancy is not considered child abuse. So it hardens us as medical providers in this mandatory reporting piece, like in a little bit of us. I feel like we all need clarification about it, so I was just wondering if you could speak to that.
I cannot. I'm looking at my DHS friends over here to my left.
I think what gets a little complicated is Oregon is considered a third harm state. Correct. Yeah, so that falls under that kind of category. And the thing is, there's layers to the call, right? Like it's not just we have a baby that's been born, drug affected. There's going to be, how's it going, mom? Where's mom staying? What's the plan? You have everything you need. You get the training of care.
I always feel some type of way when I get a microphone in my hand. So I totally hear you. I think the CARA, there's so much associated with the CARA. There's money that's been associated, right? Like, and any infant that's born drug affected in that first year, they qualify for all of these things. So I totally hear your question. It is very confusing. But I also want to give you the other perspective that the hotline is going to make the decision, right? Like you're going to make the call, but after that, it's not going to be up to you if it's going to be assigned or not. It very well could be like, you know what? We don't feel like we have an unsafe child. Maybe the hospital reports, but there's a really great setup with dad. Dad's here. You know, we really only need one protective parent to be involved for us to be like, okay, that child is safe.
I think the confusion for me is that if child abuse has not occurred, right, then why are we making that call, right? And so if we know babies get born and child abuse has not occurred because that's not happening, there's this threat of harm piece, right? But we are all providers seeing, is there a threat of harm? And so that's just, I think there is some confusion. For example, Washington State, they use a notification system, and they have an algorithm, and the notifications don't go through child welfare. The notifications go to help me grow. And so, but in my thinking, to what I'm thinking about it is I'm saying, okay, we're making this notification, but we're also making it to the child abuse hotline. That seems like a conflict of interest. So just something to think about, just sort of like thoughts about it.
That's awesome for bringing that up. Yeah. Yes, that was well needed.
And I appreciate Natalie's perspective as an employee of DHS about making a hotline call, but a hotline call is not without, even if it's closed at screening, it's not without impact. Because how many of us have looked at, well, I don't know, those of us at people at DHS and me as a lawyer have looked at where there's been multiple calls, and that is taken into account, even if they are closed at screening. Right. It's taken into account for in the future making a decision, and so I think it is problematic, and I know that the agency's position is, you know, if in doubt, report, because the agency wants to be making those decisions. But I would encourage you all not to give up your own decision making as people who are licensed professionals around what you should and shouldn't report. And I don't know that I can give you a firm answer.
Yeah, I feel weird about that too. I don't know if this can be answered, but I kind of, like, I feel that, and I sort of feel like I'm with my people right now because it's sort of like a passion for me and sort of my journey, and just that, like, having been around parents and being a parent myself that I haven't been personally, well, kind of been impacted by the child welfare system, but like, I just feel like it's not as, like, now that I am a mandatory reporter and I'm a social worker as well. Hi, I'm from Women's Healthcare Associates. I'm Molly, so I think we've talked on the phone a bit. But anyways, so I just feel like not very many, like, not necessarily like my colleagues specifically, maybe some of them, but like this idea of like really considering, like, what, like considering all these like situations, like, are we being transparent? Like, are we really, you know, being careful about these calls and like talking to the person and like letting them know what's going to happen, and like not just making these cold calls like without even letting them know we're going to do it because, oh, is there a threat of harm if we don't call, you know, if we can't let them know because maybe they'll take off, but like just for no reason, right? Like, do we have a real reason to think that could happen, right? Not just because we think that there could have been abuse happening. So I guess like my question is like, how do we sort of educate or like communicate that as like one person with other colleagues and other mandatory reporters?
I think it's important, like one of the biggest things, like I said, is as I'm a mandatory reporter and I'm the one that's making that phone call, and I'm gonna be responsible if a kid could be removed from a parent's care. And so in considering all that, I'm the first contact when I make that phone call. And so that's why I say it's important to be able to have all that information of what's happening, where I have a mom who has disclosed that she has a substance use disorder, but she's also going to treatment, or she's engaging in treatment and different things like that. Like, that's gonna have a different impact when I make that call and I say those things versus I just had a mom who just delivered and her and baby tested positive. And so that's where I say it's important to have the knowledge and the information of what is happening with this family, what are their goals, what are their outcome or their desired outcomes, and what is the parents doing to be able to support that. And also, like what Nellie said, in the state of Oregon, we need one active involved parent to be able to reduce them not going into the child welfare system. And so who is the dad? Or if there's not a dad, is there a willing family member? Because they also can do like a family plan and different things like that. So just understanding, like I said, the whole picture and the whole compass of kind of what's happening.
I was just curious, like, if there are resources available for mandatory reporters. I'm a provider for Multnomah County, and I feel like this doesn't come up that often, but often there is like a gray area. And maybe it's just like coming up with a network of people like coming to things like this and just meeting people that I can call. And I've been told you can call the hotline and give them like a hypothetical situation. And like not give any patient information, just to say like, is this a situation that I should report? I'm just curious if that's like, not to doubt the folks that are answering the phone line, but just curious if that's the best resource or if I should like just meet other colleagues and ask them.
I mean, I personally suggest a lot of our colleagues to identifying like wherever you work at, is there a person that has more expertise in making mandatory calls and understanding kind of what's going on and different things like that. I mean, you can definitely, the thing about, if you were to hypothetically, if you were to call the hotline, if you were to have hypothetically, it's gonna end up resulting in a hotline call. So I'm not going to detour anybody from doing that, but I'm just saying that if you do that, more than likely it becomes a very interesting conversation. Just saying. Yeah. 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 Yeah.
Nellie has a response, and then I'm coming to you, Nicole.
So I actually, on the side, also I do everything, you guys. I also do mandatory reporter trainings, and I can tell you, you can absolutely call the hotline and ask. I mean, they get calls, hey, is spanking child abuse? Because I heard about this kid that got spanked. Do I need to call this in? I mean, they can absolutely do that, and they are happy to do that.
Okay.
Hello, everyone. Nicole here. I've been waiting on this moment. I just think about, oh gosh, there's so many thoughts running through my head because I work for Project Nurture. So we oftentimes have like different scenarios, and what makes it really nerve-wracking even for us who are working with the client is that we don't know what we're gonna get when we get the client. We may see a client like ready to engage in treatment, doing all the things like checking off all the boxes, and the DHS worker might come in and meet a whole bunch of different things, and it makes it a lot more difficult knowing that just saying DHS is a trauma activation in general. I've had DHS, I mean, I feel like it's been ingrained in my brain since I was born. It's a thing that you're always gonna be afraid of. Even people who don't really have the risk, you hear DHS and it just feels like, I'm in trouble, I didn't do it right, I'm a bad person. So it's really a difficult situation when you don't know what you're gonna get. Like when you call the hotline and you're hoping that it's an open shut kind of situation, because it should be. I should on myself, sorry, Chelsea. But that's not what happens, and then it turns into being a totally different scenario. So I feel like it's a lot harder. It's a lot more challenging to present the situation to a client when we don't necessarily know what's gonna happen either. If I call and say, hey, hypothetically, if this was going on, what's gonna happen? Then they send me a worker that is not doing what you said on that hotline call, and then we have a pickle. We have a pickle. But I think that just recognizing that as automatically being a trauma response or hearing DHS in general. But most of our clients, a lot of our clients, we just kind of talk about it from the very beginning. We talk about all kinds of different scenarios. We talk about what could and may or happen, just to give them the idea of these options, and then we start planning right away. We start wondering, what are you willing to do? DHS might want you to go with whatever your ASAM assessment says, but you might want to start at IOP, and that's a good plan because, you know, you got to be able to trust what the counselor's saying is the best option here too. But it just always feels like it's not so much a collaboration. Not always, I shouldn't say that. Breathe. Jesus, take the wheel. Sometimes it doesn't feel like a collaboration. Sometimes it feels like we're against each other. And we're writing for our client. I'm gonna write for my client because I want them to trust me, but it feels very much like we have to like battle it out, or it feels like war and not like collaboration, and that really like, it hurts the trust that I have to report as well. Even though I know I'm a mandatory reporter, it's hard for me to want to call because of the experience with the last client who really didn't need as much, but she got everything, you know? Boom.
Yeah, and I think that's where it comes from of, as like my experience, obviously working for child welfare for 7 years, of kind of like knowing what to do and knowing our own personal rights, where like if you feel, because I've had that where I've had a DHS worker come and I'm like, ooh, I don't like that person, and I feel like you said, like they have the outcome, like they determine what could happen, and things like that. But I think it's also important of like, hey, I asked the questions. Who's your supervisor? You know, who is the branch manager? Yeah. To be able to have those conversations, because and to be able to report, because like they're gonna if we're doing something wrong, or if they feel like they're interfering with their process, they're gonna call and they're gonna report us as well. And so it's important to, if we have a concern, or if your client or your patient has a concern, of like being able to advocate, or you know, having them advocate for themselves, to be like, you know what, I'm gonna call your supervisor, and I'm gonna talk to your supervisor, and being able to, it's also empowering them to be able to do that, because we're all humans, and sometimes for whatever situation or whatever, that someone may be having a bad day and they may not experience how they're coming off and things like that. So I think that's just important to be able to, what I always do when I work with a DHS worker, things like that, I ask for a business card, and I ask who your supervisor is and what's the phone number. Yeah. Well, when they, well, not, no, sorry, no, not right away. At the end. But, you know, or, I mean, depending on the situation, like they give me, you know, I always ask, hey, can I have a business card? You know, and then like, oh, you're from, making sure the information is correct, and things like that, because it's just important, like you said, of like what happens in the room. And if there is a concern, just like we want, you know, sometimes there's good outcomes and sometimes there's not so good outcomes, and things like that. But it's just, like I said, we're all held to a standard and different things like that. And so it's just important. If something has gone wrong, if experience may have been bad or something like that, I've definitely encouraged, you know, to send an email to a supervisor, talk to the branch manager, and different things like that. So definitely that is one tool to be able to utilize for education and knowledge for yourself as well.
So we have about 8 minutes left. I've got a question here, and then I'll come across the room.
So I just wanted to touch on something that was like playing through my mind the whole time, and then I thought it was answered, but then someone said something about a family member who can support. So are reporters able to, on behalf of their peer, client, whatever you want to call it, are they able to dictate to DHS, hey, I don't want my mom to be an option for my child to go to? There's a lot of like trauma with some of the women I see who've had their kids taken before, and if that kid was placed with mom previously and then mom like didn't let them see kid anymore and like took away their rights, like that sort of thing. Can we as mandatory reporters request that on the behalf of our person? And If so, yeah, can we?
So as mandatory reporters, I mean, we can report what we know. And things like that. So we're reporting what we know and what we were told as far as that goes. But as far as like us really being able to dictate like what happens as far as the case plan and things like that, obviously we're not DHS and they do their thing. So no, but you're reporting the facts and reporting what you know. And then you just go from there.
Oh, hi, my name is Chris Anderson. I'm actually the recovery support team supervisor for ODHS. So I'm stationed out of JDH. And hey, Chelsea, how are you? We chatted last week. I think I helped tee her up for this conversation, so I sent her the definition of threat of harm. So, and I think especially for folks locally, one thing I want to keep in mind, I think Nellie and Whitley up there didn't do a great job in introducing themselves because they work for the recovery support team. And so they are outside of a branch. They're part of the FIT collaborative, so they work with a lot of our recovery navigators through Iron Tribe Networks. They also work with the Morrison Peer Mentors. They lead that monthly meeting. I think getting information about supervisors, branch managers is great, but if you're feeling like you're running into these barriers in terms of how these caseworkers interacting with the parent, I can get Chelsea the contact information. That's one of the things that they're supposed to do because they're coaching and training these staff to interact with not just our clients and how they speak to them. A lot of the talk about that person first language is what they're trying to model, but especially for younger caseworkers who don't have that experience, they see substance use in a black and white kind of moral perspective. They kind of get locked into prove an allegation rather than to assess whether or not a parent is safe or not. Because that's where that other parent comes into play. Maybe there's a mother who is struggling with substance use disorder, but the father is well aware of what's going on. It's not so out of control where she's being left alone with the child. That's where we don't have to become involved. Or even if we do become involved, there are different layers to that. Because, there's a lot to unpack, but you were talking about the ASAM and levels of treatment. When we do a safety plan, we can't dictate where a parent goes, only the court can do that. And so I think if caseworkers are presenting things that way to you, that's inappropriate. And I think that's, again, where you reach out to Nellie and Whitley. We can encourage parents to follow the treatment recommendations, but at the end of the day, whether they're in residential or staying at home and going to intensive outpatient treatment, if this child has been determined to be unsafe, there's a safety plan in place. So that's what's important. Can we manage safety in the home, in residential? So the parent does have latitude to do that. Sometimes the courts might make their own decisions. I know that Jennifer has run into that, and I imagine, where they kind of go off books. But I mean, I would really encourage, especially, and I'm really bad with where everyone's from, but for the Project Nurture folks, again, I'll get Chelsea your information. I really encourage you Thursday of the month at JDH to come join us. We'd love to have you part of the FIT collaborative. But I'll let Nellie work on that. Thank you.
All right. Thank you all for your participation. Thank you so much.